I'm also going to talk about some decontextualized tests. An oral mechanism exam, we can learn a lot from that. Evaluation of respiration. So with voice disorders, they do recommend looking at breathing, acoustic or other instrumental assessments, low-tech assessments of resonance, and then formal articulation tests, especially for cleft palate or resonance disorders. So I'm not going to go over all the details of an oral peripheral examination, but when we're looking at voice and resonance disorders, this is something that we really can do and should include at a minimum, looking at lips, tongue, jaw appearance, velar elevation and appearance. So we might always think that a cleft palate is always caught in a medical setting, but it's amazing how many are not, especially a submucous cleft palate, and how many are caught by someone else looking in the kiddo's mouth, a dentist, a school speech language pathologist, sometimes a parent who goes, are they supposed to have two uvulas? Looking for any kind of potential neurologic involvement or differences in their diedochokinetic tasks. This is, again, Leaders Project, a video that shows a pretty comprehensive oral peripheral examination. Assessments of respiration. So, again, you may not know what, you may know or you may not know the etiology of a voice disorder in a child, and you're gathering information that can be helpful in figuring out what additionally is needed. The S to Z ratio is not diagnostic, but it is informative. So the S to Z ratio is where you look at how long can they prolong an S sound versus how long can they prolong a Z sound. In healthy adults, it's close to 1. In children, it's a little bit different. I actually have some norms after this. But it's a measure of vocal efficiency. It doesn't necessarily mean that there's a laryngeal problem. It can be a coordination issue. It can be a learning issue. But it does give you a measure. Maximum phonation time. How long can someone sustain a sound? That can have functional consequences for how long are they able to read for? How long are they able to talk in class? Do they need to take a lot of extra breaths? Observe respiratory patterns. And this is for, all kids with potential voice disorders. So kids who have neuromuscular disorders, but also kids who have, nodules, vocal fold paralysis, other things. They may try to conserve breath by breath holding. So you might hear kids who start talking, let's say we're counting 1, 2, 3, 4, 5, 6, 7, and then let all their air out. They're holding their breath, kind of trying to conserve it. Shallow clavicular breathing, we know not the most efficient breathing pattern. Stridor, I would say is definitely something we want to be really concerned about, because that implies that there's a narrowing somewhere in the airway. Okay, I'm not going to read through these, but for your reference, these are maximum phonation time and S to Z ratio norms for ages from 4 to 12. So I know nobody has a voice lab in the school, right? There's a surprising number of measures that you can take without a formal voice lab, and those can be useful for progress monitoring. They're, again, not necessarily diagnostic, but they're descriptive. So this is an article from ASHA, well, AJSLP, recommended protocols for instrumental assessment of voice. And so it is a bunch of voice experts came together and determined what the recommended protocol would be for instrumental assessment. And I'm going to talk about the acoustics. They also recommend laryngeal evaluation, laryngeal exam, which we can't do in the schools, obviously. But these are some of the measures that are recommended. So vocal intensity in decibels SPL, vocal frequency, and vocal signal quality. And then these are measures that are not listed in this article, but there are other measures that can be taken to characterize the voice. So again, we're not going to get into all of the details of this, but there are some low cost or free acoustic tools if these are measures that you think that you might be taking. So Pratt Completely free. You can download it to any computer. It's called Pratt Doing Phonetics by Computer. This is a link to the website there. And you can take fundamental frequency. You can take another measure I'll talk about, cepstral peak prominence, decibel level, jitter, shimmer. There are some apps. These change pretty frequently, so I don't have a specific list. But the Physics Toolbox Sensor Suite and Sensors Toolbox are some that some people would use, especially for fundamental frequency and loudness. So fundamental frequency and fundamental frequency range. So what is the mean speaking fundamental frequency and what is the student's pitch range? These can be obtained with those relatively low tech measures. And we should know that the fundamental frequency does change quite a bit with assigned male puberty, less with assigned female puberty. Okay, so I'm not going to get into, I could talk for hours on voice science. Honestly, I love it, but I'm not going to. But this is a measure that is gaining prominence, not, pardon the pun, cepstral peak prominence. So it is a spectral measure. Again, I could talk for hours on it, but I won't. Basically, it is a measure of vocal signal quality. It measures, it basically takes the voice signal, and it can take it from a sustained vowel or from running speech, and it measures the amplitude of this dominant cepstral peak, which is a proxy for the strength of the fundamental frequency, the strength of the primary pitch of the voice, relative to the other noise. So if you think about a voice that's really hoarse, it's harder to pick out that fundamental frequency, the pitch, from the other noises in the voice. Take home from this is, especially if you're reading a voice report from a clinic, or if this is a measure that you want to use, higher cepstral peak prominence is associated with better voice quality or less dysphonic voice quality. So if you are looking at these norms, if you're taking any of this data, these are acoustic norms for students 4 to 19. So this, oh, looks like I forgot to put, this is fundamental frequency, sorry. Fundamental frequency. Jitter is perturbation, frequency perturbation. So again, another indirect measure of vocal quality. With jitter, higher jitter percentages are more dysphonic, lower are less dysphonic. Shimmer, amplitude perturbation. So again, another measure of kind of the clarity of the signal or the regularness of the voice. And again, higher shimmer is more dysphonic, lower shimmer is less dysphonic. And these are normal shimmer values for kids. And then I'm not giving cepstral peak prominence norms because there are norms, but they differ depending on the software used. And there are no norms for the freeware. There are norms for there's a acoustic suite called the Pentax VisiPitch or the Computer Speech Lab. That does have normative data, so you might see it in a voice clinic report, but still working on it for the freeware. And it's just because they calculate it slightly differently. For adults, we know that a cepstral peak prominence of less than 14.55 decibels on a sustained vowel or less than 9.3 in the rainbow passage was consistent with presence of a voice disorder. But we also know that it increases with age. So younger children actually have a lower cepstral peak prominence than older children. Okay, all that to say, a lot of tools you can use. So when you're putting the pieces together, none of this is going to tell you the etiology, right? So that is important in planning treatment. So you might know from medical settings, you might know from what the parents have told you. Again, we're treading in challenging waters here, but does it need further medical evaluation, or do we know the cause? But what we can do is talk about what is the academic impact, including social, emotional, peer relations, characterize and describe functionally across contexts, and determine potential for change. So all of this are things that you can begin to look at. And of course, when you're summarizing your data, you want to consider information from a variety of sources. We know we don't rely on a single data point. We would never in any setting. Just say, oh, their CPP was high, therefore they qualify, or their jitter was low, so they don't qualify. So things like that. And we need to have sufficient information to consider students' previous rate of academic growth, whether that has changed, and barriers, facilitators, parent-child input should be considered, just like with any communication disorder. I want to go on to talking about different causes, etiologies of voice and resonance disorders.
So Maya, I don't see any in the chat, but I was thinking about the different assessment tools you said that we could use in the schools, and I totally get and understand the perceptual rating scales, but you just lost me on the last few slides. And so if I'm lost, I'm hoping that some of my other school-based colleagues are with me. I'm not sure, like, when would we want to use the CPP, and is that, is there training involved? Would that be time intensive? Because we don't, would it be when we are worried about a student's pitch, loudness, and intensity? I mean, are you going to talk about that in the future, or,
I speak to it a little bit now, and I would say, so if you're concerned about their pitch or intensity or their loudness, I would take fundamental frequency or loudness levels. Whether you use that, whether you can get an app on the phone that does that. The CPP, there are trainings, there are a lot of resources out there. It's becoming more commonly used in voice clinics, and I like it. It's not obviously 100% measure or anything like that, but it's actually relatively easy to take once you know the software, and the software is free. And so you would basically have the student say, ah, and read a short sentence. And then you basically go through clicking a few buttons and you get a number. I can direct people. So the website that I linked to actually has specific instructions on how to do it. It would be something that I would use maybe to track change. So if at the beginning of treatment, they have something that is at a certain level, you could use that and kind of use it across the semester to go, okay, it's changed a little bit. And so the perceptual rating in combination with that, in combination with child report, parent report, teacher report. So it's another data point.
So would you use it for a student who possibly has like maybe vocal nodules?
Yeah.
Okay.
Yeah. So any kind of hoarseness.
Okay.
So vocal nodules, vocal fold paralysis, again, it's not going to diagnose that, but it's going to tell you the impact of that on the vocal signal quality.
Okay.
And so, people might kind of, it's one that's become more prominent in the past several years. The other ones that you could use in that would be the jitter and the shimmer. And I don't know if people remember that back from voice class or speech science, but they are still commonly used, but I think CPP in a lot of clinics is sort of replacing that.
Okay. And then just to compare or contrast with some of the other information you shared about hypernasality, hyponasality, velopharyngeal mislearning, there would be different. So it's for voice, not for resonance.
It's for voice, not for resonance. And to my knowledge, there are no low cost or free acoustic measures for resonance.
Okay, great.
Those are all.
Okay, just wanted to clear that in my mind. Thank you.
Yeah, and so I include that because it is a free or very low cost measure that can be incorporated. And also, if you are looking at reports from voice clinics, you might see it. So then if we go into why do students have voice disorders? This is definitely not comprehensive. But some of the more common things we might see. So everybody knows nodules, cysts and polyps or other benign lesions, mobility impairment, meaning a paralysis or a paresis. And I'll go through all of these in a little bit more detail. The papilloma, congenital anomalies. So you can have, people can be born with a laryngeal cleft or a laryngeal web. Scar or sulcus is more of like a defect in the tissue of the vocal folds. And then these two kind of increasing in, I don't know if they're increasing in frequency or just increasing in people's awareness of them, but I do think as we have more and more kiddos who are born very early and have a prolonged NICU stay, they may have some of these, the posterior glottic insufficiency post-intubation, which is a lot of words, basically means the back of the glottis doesn't come together, potentially from having a breathing tube in there for a long time. And then sometimes kids who've had major airway issues have a reconstruction that often leads to some voice problems. So their breathing issues are better, which has been the main issue their whole life, but then they're still hoarse. And I say this because a lot of times the families will know the medical history on these. It's not necessarily a surprise, but knowing that the voice is related to that is something sometimes that doesn't come across. Okay, so I have to put this in pitch perfect. So I came into speech pathology as a singer. I remember nodes or nodules were like the scariest thing you could have. They're really pretty common, and they're actually the most common cause of voice disorders in children. Okay, so they kind of look like this. They're little bumps that kind of look like calluses, and they're usually pretty symmetrical. They sort of match. It's right where the vocal folds hit. We assume that they're caused by repeated impact forces. So this is kind of the classic heavy voice user, vocally exuberant student, maybe yells a lot, fairly extroverted, outgoing, sometimes some impulse control challenges. And what's that going to sound like is often difficulty getting soft and getting loud. So sometimes they're actually, they're the kid that the teacher always says, can you use an inside voice? And sometimes they actually can't, because the vocal folds are a little stiff and it takes a little more breath to get them moving. And so in order to talk at all without their voice breaking up, they get louder. They often have trouble getting soft too. And their voice, using those descriptors, might be rough, might be breathy, might have a lower pitch, might sound strained or have more effort, and might have trouble getting high. So they might notice problems in music class even. Okay, so I'm using a hypothetical to kind of talk about the different assessments and where they would fit in. So let's say we've got an 8-year-old second grader. We know, so this is, perfect world scenario. We already know that he was diagnosed with nodules at the ENT after his pediatrician noticed hoarseness. He's in school and it's been brought to your attention maybe by both the parents and the teacher. So how do we fit this into our comprehensive assessment? His academic performance is basically at grade level. He's meeting expectations in that way. But you observe him in class and you notice that when he went to answer a question, his voice broke and he couldn't quite finish the sentence. He had trouble projecting his voice during a small group activity when the rest of the classroom was loud. On the playground, he yelled a lot, and you noticed that he had increased hoarseness after recess. The teacher fills out a checklist, the parent fills out a checklist. Kind of talk about that here. The parent does provide the ENT evaluation information, which confirms that it is nodules. Student is aware of their voice difference and they notice vocal fatigue. They notice that they lose their voice by the end of the day, and they say that they're embarrassed because people have been noticing and asking what's wrong with their voice. The parent reports that hoarseness has been worsening and that the kiddo is a heavy voice user. So you do some perceptual ratings. I've got those on the next slide. But you notice that certain therapy probes, you have them do, let's say, some lip trills and humming, and notice that their voice is clearer, and the student notices that it's less effort. So let's say you did the perceptual rating. Your overall rating was a 54 out of 100. There should be a 1 there, which corresponds to a moderate roughness. Or moderate, sorry, I need a comma there. Roughness was 57 out of 100. Breathiness is 42 out of 100. Strain is 63 out of 100. Loudness during the tasks that you're testing is normal. And you notice the pitch is a little bit lower than you'd expect for his age. Okay, so these are kind of going to be your baseline ratings. You do an oral mechanism, it's normal. His assessment of respiration, he's only got a maximum phonation time of 4 seconds. You compare that to the norms, that's low for his age. You also notice that he's taking pretty shallow shoulder breaths, clavicular breaths. You do take these acoustic measures and notice that his Kestrel peak prominence in speech is 5.2, which would be low, and his fundamental frequency is low for an 8-year-old boy. Okay, so you've got all this information. So I can't make the decision on how that would qualify a student, but you can kind of put all that together and think about what would the case be for qualifying, not qualifying for services based on the information that you have. And then I also like to start thinking about how would you build goals from there. So that's one example of how you might use all of these different assessment parameters.
Hey, Maya.
Yeah.
Before you go, I noticed that you have several other voice disorders and then the resonance. And just in the interest of time, I'm wondering, just because, I mean, correct me if I'm wrong, isn't vocal nodules, wouldn't that be like the number one?
That is the most common. Yeah.
Okay. So having spent some time there, could we maybe then go down to resonance? Because,
yes.
Okay.
All right, that's a great idea. I'm just going to click through these. So why might we have a resonance disorder? So we could have a cleft palate, submucous cleft palate, non-cleft velopharyngeal insufficiency, a neurologic cause, or our favorite, velopharyngeal mislearning. So just for a definition, kind of review, cleft palate literally means a congenital opening in the palate. And these are the different types of clefts you might see. This happens very early in gestation, and it might involve the lip, it might not. So you can have just a cleft of the palate, you can have just a cleft of the lip, or you can have a combination. It would be incredibly rare for an overt cleft palate not to be identified either prenatally or at birth. I've seen a handful in my life, very rare. They are usually followed by a cleft palate or craniofacial team. If they're not, would be followed by at least an ENT or plastic surgeon. So they're going to have some sort of medical follow-up. Typical timeline, a lip, depending on where you are, is typically repaired at 3 to 8 months, where the palate is repaired around 1 year. And the reason for that timing is the beginning of speech sound development or word development, right? So we want it repaired before they're really truly verbal, but when they've had enough growth that it's going to hold and that they're old enough to tolerate a big surgery. So students may continue to have speech or resonance disorders after a cleft palate repair. So you can have a child whose palate's been repaired, but they're still hypernasal, or they still have speech sound errors related to the cleft palate. Some of these respond to therapy, and some of these require surgical treatment. And it's often not an easy, immediate decision, even from somebody specializing in cleft palate on the team. So let's say we have a 6-year-old child. They were adopted from overseas. And this is often a case where sometimes surgeries overseas are excellent, and sometimes they are done by either people coming in from overseas and doing it incorrectly, or a lot of different reasons. And we wouldn't have that medical history necessarily. But her palate was repaired overseas at age 2. And after she came home, she was seen by a craniofacial team, and she had a secondary surgery due to continued hypernasality. This was 4 months before your evaluation. She's presenting with moderate hypernasality and cleft type speech errors. So educationally, she's meeting expectations for grade level. But when you observe in class, she's reserved in interactions with other students. She does play with other children on the playground. The teacher's main thing that they point out on the checklist is that they have difficulty understanding her, and the parent is really concerned with her intelligibility, as well as how she might be doing in school. So we know from medical history that the palate was repaired. She's had a secondary surgery. The surgeon believes that their palate is now functional. Also, she has had frequent ear infections and has tubes. You interview the student. You see that she knows that her speech sounds are different and some sounds are hard for her. So we got child aware, parents are aware. Parent has concerns for intelligibility as well as for academic and literacy skills. She's in kindergarten, so really kind of pre-literacy kinds of things. But parents are worried that she is not going to be keeping up. So you do some perceptual ratings. You notice that she's moderately hypernasal, but it's inconsistent. So you try some stimulability. You do some nasal occlusion, and Sometimes there are differences when you plug her nose and sometimes there aren't on some sounds. So you check on the consonants that were in error, which based on both contextual and decontextual testing, she had accurate reproductions of P, B, T, D, M, and N, nasal substitutions for sh, ch, and j, so for those, glottal stop substitutions for k and g, and audible nasal emissions on S and F. So she's making a sound, but she's got a little right nasal rustle coming through. And you do the stimulability testing and realize that with some therapy probes, she is getting, she's getting k and sh on just with a few tries. You also see that she's got a scar from her palate repair, some visible dental crowding. Again, same things, find the same things on the articulation test that you found in the speech sample. So we've got these glottal stop substitutions, which would be considered a compensatory speech sound error. We've got nasal substitutions, which could be velopharyngeal mislearning, could be a compensatory error. Audible nasal emissions on these, but then she's got accurate productions of these, and these are produced with good oral pressure. So putting this together, you start thinking, okay, we know that she's had the palate repaired, she's still having these issues, she's still hypernasal, but she's getting these sounds. What I start thinking is I think her palate is working, but I think she has some mislearning and some compensatory errors that could be addressed in therapy. Real quick on submucous cleft palate, this means that the palate, the mucosa is together, but the muscle is not. And you can have different degrees. You can have a little tiny bit of a submucous cleft palate. You can have all the way along the soft palate. The classic appearance includes, probably remember from graduate school, that bifid uvula, zona pellucida, which means a little bit of a blue or gray or clearish zone in the soft palate. And if you were to be brave and feel in the mouth, you might feel a notch in the hard palate. Just to mix it up a little bit, you can actually have a submucous cleft palate with none of these. That's occult. This is a little harder to diagnose, but sometimes we can figure it out through some stimulability testing. Often they do need a medical exam to figure it out for sure. But submucous cleft palate can have a really variable presentation. If there are difficulties, they might have had early difficulties with bottle and breastfeeding. They might have had frequent ear infections, and they might have hypernasality or difficulty with high pressure consonant sounds. And again, sometimes this is not diagnosed until later because the errors are not quite as obvious as with an overt cleft palate. And then velopharyngeal mislearning. I talked a little bit about this earlier, but structurally and neurologically, all is typical. They have no submucous cleft palate. They have no neurological disorder. They might have really atypical articulation errors, and these are generally present on some sounds and not others. Phoneme-specific nasal substitutions. So for S or for phoneme-specific nasal emissions, meaning they actually have the articulatory placement, but they're directing some air through their nose, or phoneme-specific hypernasality. I've actually seen a couple of kids who had hypernasality on a single vowel, and that ended up being a velopharyngeal mislearning that they fixed through therapy. Much more rare. I think the classic example of this is actually S's, and I have no idea why some kids develop that error. So let's take a case example. We have a 7-year-old boy, no significant medical history. His speech just sounds different. Everybody's kind of going, it's just, I don't know what's different about it. He's hard to understand and he's getting some negative attention for it. There's no relevant medical history. His parents say he's always been healthy, nothing. So you interview the student. He says he does notice that people have been noticing his S sounds especially. You interview the parent. They say, yeah, really, we had no concerns, but as he started talking and talking more, we just noticed he sounded different. So you do a communication sample, and you don't notice pervasive hypernasality, but you notice very specific speech sound errors. You notice S and F are produced as nasal, kind of a backward snort. Or sorry, S and SH, S and sh. So kind of a sound. Everything else seems typical. His oral mechanism is normal. You see nothing that looks like a submucous cleft palate. Again, on the Artic test, only S and sh are that, again, atypical nasal backward snort. This is one where I would do stimulability testing because a lot of times these are quick remediations. So one kind of stimulability I would do if somebody's producing a nasal snort for S, I would ask them to do a T sound. Now, if that's an oral production with good oral pressure, then I would have them plug their nose and make it a long T, just like you're shaping an S from a T, but we're not going to tell them it's an S because a lot of times that they've developed that match between S and, so if you just say, okay, we're going to make a new sound, we're going to make a long T. A lot of times you'll get that and then you unplug the nose and it might take a while, but you will find that they can do that S sound. Just a few other things you might see. Non-cleft velopharyngeal insufficiency. This does occur and it occurs disproportionately in 22q11.2 deletion syndrome, which you might also know as velocardiofacial syndrome, and a few other genetic syndromes. It can also happen after an adenoidectomy. So kid comes back to school after an adenoidectomy and they're suddenly hypernasal. This can be a non-cleft velopharyngeal insufficiency. Usually after an adenoidectomy, this is transient. It goes away after 2 to 3 months. If it doesn't, sometimes it resolves with therapy. And if it doesn't resolve with therapy, there may be a structural reason. And then we may also have velopharyngeal dysfunction associated with apraxia, dysarthria, and a nerve injury. Hyponasality, usually not something we're going to be treating with speech therapy, but something that you might just be aware of. Nasal obstruction versus nasopharyngeal obstruction. So allergies, upper respiratory infection, narrow nasal passages versus adenoid or tonsils. Again, you're not going to be diagnosing these, but you might just be aware if you're hearing hyponasality, these are some common causes. But I just wanted to give some resources for continued learning. So let's say you have a child with a voice disorder on your caseload. Here are some places you can go. So the UW Voice and Swallow Clinic lecture series, if you're not familiar with it, they are no cost to you CEUs. And even after the CEU period has passed, you can watch them for many years. And Leaders Project, I would recommend for cleft and craniofacial anomalies, as well as the practice portal. These are some resources that have courses on both voice and resonance, but they're for a fee, obviously. ACPA, which is the American Cleft Palate Association, and I think we're all familiar with ASHA Learning Pass and MedBridge.
Thank you, Maya, for that. And I think, you know, we don't come across a lot of voice kids in practice in the schools, but I do think it's important for us to be aware, to refresh our memories, and to think about, I like the different strategies or tools that you have encouraged us to use. Thanks a lot, Maya. And thanks everybody. Look, we're done on time. So that's great.